I know it's a short break, but we have more content to cover. Okay, so we're going to talk about fetal monitoring, or intrapartum fetal surveillance is what your book calls it. And there's different methods for doing this. The less common method in the hospital, you probably won't see this, is just the intermittent auscultation and palpation. That's a fetoscope that she's using there in that picture, listening to fetal heart tones there. And palpation, just feeling the contractions, feeling when they begin, feeling when they end. So advantages to that type of monitoring, which we don't see very much of, is the patient can be up and moving around more. They're not connected to a monitor or a machine. They have increased ability to use water-based methods, so they can get in the tub when they might not be able to with a monitor, even though the fetal monitors are getting better, and we have some that are waterproof that we can actually use in a tub or shower if patients want to. And just a more natural atmosphere, so patients doesn't feel like their labor and birth is so clinical. Limitations to that intermittent auscultation is it just provides us a small amount of information. We're only monitoring little short snippets of time. We can't see this whole long tracing. And so that small amount of monitoring, we may miss out on some events like decelerations in the fetal heart rate and things like that. Intermittent monitoring also causes some interruptions during labor. So if the patient's resting, but it's time for us to monitor, then we have to wake patient up to position them to do that intermittent monitoring. And it's also staff intensive. So if you can imagine if you were just, every 15 minutes or every 30 minutes having to listen and palpate, then you're going to be in that patient's room almost constantly listening and palpating and then recording your findings. So it's really staff intensive. Labor would have to be one-to-one. Typically labor is one-to-one with nursing care, so one nurse with one labor patient, but sometimes it's not. I worked on Friday and I had 2 labor patients, so sometimes it's impossible for it to be one-to-one. There's too many patients and not enough staff. So you can imagine that this type of fetal monitoring would be difficult with 2 laboring patients. Electronic fetal monitoring is what you'll see mostly, and that's just a little Doppler that's showing in that picture, but we'll look at the other monitors that you'll be more likely to see. Advantages would be that we get a lot of data from that labor process. We can see what the heart rate's doing the whole time. We can see patient's contraction, every contraction, the fetal response to every contraction. Gradual trends would be more apparent. So if the baseline fetal heart rate was increasing or decreasing gradually, we would see that. We might not notice that if we were just intermittently tracing or monitoring. Some patients like the constant surveillance. So some patients want a less clinical experience, but some patients want the baby on all the time. I have patients that'll call out and say, my baby's off the monitor. They've been off the monitor for like 3 seconds, and I can see it, but sometimes the baby will go back onto the monitor on their own. So, but they like the comfort of knowing that they can see their baby's heart rate and that everything's okay. And nurses could monitor more than one patient. It would have been difficult for me to have 2 laboring patients on Friday if I was getting an epidural for one of my patients, but I had my other monitor pulled up too so I could see what the monitor tracing of my other patient. So those are advantages. Limitations can be reduced mobility, even though there are some wireless monitors now. They don't work as well, but they'll kind of remotely send the information to the monitor. The belts can be uncomfortable. They use the belts to strap those monitors on, and sometimes those are uncomfortable for a laboring patient, that squeezing. And some patients don't like the technical birth when the birth process just seems really technical and less natural. So external fetal monitoring is what you're going to see typically, and those are just the 2 parts that you can see in that picture there. On the bottom is the ultrasound transducer, and that's what detects the fetal heart rate. Okay. The top monitor part that you see there is the TOCO transducer. They'll call it a TOCO, and that detects the uterine contraction. It's just a little pressure sensor, and it detects that muscle tightening up. It kind of pushes against that button, and it makes that the little hills on the graph that you'll see, and I'll show you those in just a minute. We use fetal monitoring because that's the way we can assess our baby in utero. We have 2 patients when we're caring for a labor patient. We have mom and we have a baby. So that's our only means of assessing baby in utero, or one of our only means. We can assess fetal movement and things like that as well, but that's a good means of assessing babies in utero. In order to place the ultrasound transducer properly, I'm going to go ahead and change the page here. We use Leopold's maneuvers to determine where to place that fetal monitor. The fetal heart rate monitor should be facing the fetal back, okay? Usually we just use this second maneuver. They're listed in B. And we'll just feel both sides of the baby to see if we can tell which side is the back and which side is the feet and arms and all of that. The back feels really smooth. When you're palpating the abdomen, you can just kind of feel a smooth part, and then the other side feels kind of knobby. You can feel elbows and knees and feet on that knobby side. So we know that smooth part's going to be the baby's back, and that's where we're going to put the ultrasound transducer, right on the baby's back, typically lower on the abdomen, okay? And then the TOCO goes on the fundus. You remember the fundus? We talked about that in bubble he. What's the fundus? Top of the uterus. So you're going to palpate for the top of the uterus, and you're going to put the TOCO right at the top of the uterus. A lot of patients will say, I'm really feeling my contractions low. I don't feel them up there. But the uterus is a big muscle, and so it's going to get tight all over. Even if their pain is more intense lower, the TOCO will still pick up on the fundus. That's the best place for it to be. Occasionally we'll have to use internal fetal monitoring, and that's just when external monitoring is ineffective. Sometimes it's hard to monitor a patient if they're changing their position a lot. Obese patients, sometimes it's hard to monitor the baby. There can be other factors that make it difficult to monitor baby, but in those cases we can use internal fetal monitors. The scalp electrode is the fetal monitor part, and kind of, I had a scalp electrode and I can't figure out what I did with it. I was going to pass it around so everybody could really look at it, but I need to find it before next time. I might bring it to another lecture and let you guys look at it. But it's just got a little tiny thin wire, shows a picture of it right there in that little circle, and that wire actually does go right into the top of the baby's scalp. Okay, just right underneath the skin. It sounds really terrible, but it just barely goes under the skin of the scalp. One of the doctors I work with describes it as, do you remember putting like a push or a pin, like a straight pin or a needle, like through just the top layers of your skin? You know how you could do that? It doesn't really hurt. She equates it to that. Now, I don't know if it really feels like that to the baby, but that's how she describes it to the patients. I think the skin on your head is a little bit more tender than the tip of your fingers, but anyway. But that's where that's placed. And then the internal pressure catheter is the monitor that we use to monitor contractions internally if we're unable to pick up contractions externally. So before we can place an internal fetal monitor or the intrauterine pressure catheter, what do you think needs to have happened first?
Probably active stage of labor.
Active stage of labor. We definitely have to be able to, the cervix has to be open enough where we can reach the baby's head, right? What else? Ruptured membranes. Yeah. Water has to be broken because we can't place any of that. All of that needs to go right inside, either on the baby or next to the baby, and we can't do that unless the water's broken. So typically we won't do that until patient's water is already broken. The scalp electrode is called a scalp electrode because we place it on the baby's scalp typically. We'd want to make sure that we assess thoroughly to make sure that we don't have a face presentation. You wouldn't want to put that in an eye or anywhere like that. You don't want to put it in the soft spot on the baby's head. It needs to go on a real bony spot, so you have to feel for that. Of course, you guys won't be doing any of this in clinical. Only if you decide that you want to become a labor nurse will you be doing this, but that's what they're looking for when they place that. We also want to make sure that we don't place internal monitors on a patient that would be contraindicated to do vaginal exams. Have you guys read anything about that? When would it be contraindicated to do a vaginal exam on a patient? If they're bleeding, usually, and we don't know why. If we're concerned about low-lying placenta previa, we wouldn't want to do a vaginal exam. We also wouldn't want to place internal monitors if mom has chorioamnionitis. So that's an infection of the amniotic fluid. Active maternal genital herpes. So if she has an active infection going on, or active herpes flare-up at that time, we would not want to place that monitor. HIV virus. If mom's HIV positive, we wouldn't want to place internal monitors. And we talked about that undiagnosed vaginal bleeding. So any of those types of infections that I just listed can be transmitted to baby through that break in the skin in their head when we place those monitors. So we just don't want to expose baby to that. Okay, so let's just look at a fetal monitor strip. Just quickly at a glance, what we're looking at. The fetal heart rate is listed as on the top of the monitor strip always. So if you're looking at the fetal monitor strip in clinical, you're always going to see the baby's heart rate up there, up on top. Now, in a lot of facilities, you're also going to see maternal heart rate up on that top grid as well. It's usually lower than baby's heart rate, and it's usually noted in a different color. So you'll notice that. So usually if you see two tracings on that top grid, one's fetal and one's maternal. The bottom display is always uterine activity. So you can see those little hills that are on the monitor. That's showing contractions. Okay. The interval between those vertical lines, those red lines that you see on there, is 1 minute. So that's a minute. Each one of those lines designates a minute. And then the blue portion of this display shows where the normal baseline fetal heart rate is. So we would hope that the baby's heart rate stays in the blue area most of the time. Now some of the other monitors at Saints, I think, look a little bit different. The colors are going to be different, but it's still going to be the same setup. You're still going to have contractions on the bottom, fetal heart rate on top, and maternal heart rate on the top display as well. So this shows the normal baseline fetal heart rate is 110 to 160. Okay, and so that baseline is just what it stays at, okay, for most of the time, what it stays at. So we're not counting any accelerations. We're going to talk about that in just a second. What questions do you have so far? Fetal monitor is kind of confusing. And you're not going to be an expert at reading these when you walk away from here. In fact, you might walk away even a little more confused than you were. Talk to me if you are, and we'll also look at them in clinical, okay? Sit down with your clinical instructor and look at fetal monitor strips, and you'll kind of get the hang of it. But you're not going to be asked to read fetal monitor strips for the exam either, so don't get nervous about that, okay? It takes a long time to become proficient at reading fetal monitor strips. So fetal heart rate variability is one thing that we're looking at when we're looking at a fetal monitor strip to assess fetal well-being, okay? The variability describes the fluctuation of the heart rate, of the baseline fetal heart rate, that causes the printed line to have like irregular waves, okay? So you can see on this, some of them don't have any waves and some have a lot of waves down here. We get to marked variability. So it's kind of the amount of squiggle, okay? If it doesn't have any squiggle at all to it, we're going to call that absent variability. If there's just a little bit of squiggle, and that's measured in beats per minute, okay, so less than 5 beats per minute, you can see that on the little graphing paper, then that is going to be minimal variability. And we don't want to see absent or minimal variability, at least not for a very prolonged period of time. Those can show, it can mean our baby's hypoxic or acidotic. Certain drugs can cause that too, though. So either street drugs that patient may have taken, or even some drugs that we give mom, like narcotics or magnesium sulfate, can make that can cause decreased variability. Fetal sleep cycles can cause decreased variability. So we might see this, usually it's not absent, but minimal variability when babies are sleeping. But fetal sleep cycles should only last 20 or 40 minutes. 20 to 40 minutes max is about how long a baby will sleep in utero. So when I see minimal variability, I don't get alarmed right away, especially if I've had good variability to before. I'm going to just watch that baby's probably sleeping. And if I haven't given her any drugs and she hasn't just walked in off the street. Moderate variability is shown in that third graph there. And so there's a lot more squiggle. That's 6 to 25 beats per minute variation. Okay? When we're counting that, this doesn't show it, but on the fetal monitor strip, you'll see numbers on the side too. Okay? Which denote how much that strip is moving. You can look at that and see that it's moving up 5 or 25. You know, you can see how much it's moving, how much variability you have. And that's just a reassuring sign. If we have moderate variability, we're reassured that our baby is well oxygenated, tolerating labor okay, a normal acid-base balance at the time of monitoring. Okay? So just in that snippet of time, our baby's good. And then marked variability is greater than 25 beats per minute. You can see that it's just kind of all over the place. Marked variability can mean that baby is trying to compensate for having low oxygen, but more often than not, this marked variability is just baby moving a lot, or stimulant medications have been given. If we've given anything like terbutaline or anything like that, that can kind of stimulate baby's heart rate. Okay? Variability is kind of confusing, but really it's just the amount of squiggle that you have in the baseline. Okay? Questions you have about variability?
At what point would you give the data for a C-section if the baby's already all over the place?
Well, for marked variability, it's not typically concerning. It's not going to stay marked if our baby's oxygenation status is not good. It'll eventually trail off into this minimal and then absent variability. Okay? So it's not going to stay marked like that. So if it's sustained like this, I'm not typically going to be super worried about baby. But we don't typically see this pattern sustained anyways. We usually just see it with movement or something like that. So now with the absent variability or minimal variability, if we've gone longer than like a 40-minute sleep cycle and that continues, and we've done some things, because we can do things to kind of stimulate baby in utero. Scalp stimulation is one thing that we can do, where you actually use your fingers to rub the top of the baby's head, and we should see some variability from that in a baby who is well oxygenated and their central nervous system is intact. We can also do acoustic stim. That's what we call it. And it's a little buzzer. It's a little thing that you put on the mom's abdomen, and it causes a vibration and a buzzing sound. Baby can hear it and feel that vibration on the uterus, and that should give us some variability. So baby should respond to that, and if baby responds to it, then we know baby's okay. But if we do those things and we have prolonged periods of minimal variability or absent, then we would probably need to act on that if we've tried to remedy that. Okay? Does that make sense? Okay. All right, we're going to talk about accelerations next. This strip is a little bit blurry, but you can see our baseline is right here in the middle. This middle portion right here. When we're talking about baseline, we're not talking about big jumps in the baseline or in the heart rate. We're looking at what it's staying at most of the time. Okay? So that's our baseline. That's moderate variability. Okay? We've got a good amount of squiggle there. But then these big elevations in the heart rate are called accelerations, okay? There's an acceleration, there's an acceleration, there's an acceleration. You can see that heart rate really boosting up there, okay? We want it to go above the baseline, typically in a term pregnant patient, in labor, everything's good. We want that to go up by 15 seconds. And again, there's little measurements on the side. Can't see it in this picture. That'll show. So we want it to be 15 seconds long by 15 beats elevated at least. That second one there is a lot more than 15 by 15, but that's as good as you can get. It's a 15 by 15 acceleration. Okay? Let's go back. I'm not done talking about accelerations. So they're just temporary, abrupt elevations in the fetal heart rate above the baseline. We like to see accelerations in the fetal heart rate, but it doesn't, if we have a lack of accelerations in fetal heart rate, it does not mean that something's wrong with our baby. As long as we have moderate variability, then we're reassured that baby is good. But we like to see accelerations. It's just another reassuring sign. All right, so that's accelerations. Decelerations, opposite of accelerations, are when the heart rate drops periodically, okay? And there are 3 different types of decelerations that we look at. There's really 4 that we might document, but we're just going to talk about these 3 right now. Early decelerations, variable decelerations, and late decelerations, okay? Early decelerations are caused by head compression, and you can tell that they're in early deceleration. All of these are going to be pretty much in relation to contractions, except for variables. They can come anytime. But an early deceleration mirrors the contraction. The heart rate starts to drop as the contraction rises. You can see that in that top picture. And it returns to baseline by the end of the contraction. It is back up to baseline by the end of every single contraction. That's how we know it's an early. That's what it's called, an early deceleration. Again, caused by head compression. It's a vagal response that the baby has to pressure on its head while it's moving through the pubic bones, the pelvic bones, okay? So that's a normal deceleration. We expect to see early decelerations in a laboring patient. It's a reassuring sign, actually. Baby's moving down to even have its head being pressed by those pelvic bones, okay? And we don't have to do any interventions if we see early decelerations, except for sometimes if I haven't seen early decelerations and I do all of a sudden, sometimes I'll check my patient to see if she's progressing a little bit faster. But there's no interventions for early decelerations. They're normal, they're fine, they're reassuring. We don't have to do anything about that. And you can see on this strip, too, we've got moderate variability in between. You can see that we've got good kind of squiggle in between contractions, too, okay? The second strip shows variable decelerations, and we know that they're variable. We call variable decelerations, we know they're variable because they drop off quickly, okay? If you look at that, it doesn't mirror a contraction. It's not a gradual drop and a gradual rise. It's an abrupt, it's a sharp drop in the heart rate. See these sharp drops right here. That heart rate drops off quickly and usually returns just as quickly. Often they'll look like a real sharp U or V-shaped, okay? Variable decelerations are caused by umbilical cord compression. So if the umbilical cord is, do you have a question? Huh?
Bedtime?
You can, come on.
Microbes? You did it wrong.
Okay. Do you want me to have them do it when we're done?
Class.
Yeah.
I looked at it, I thought, this doesn't look right.
Okay, variable decelerations have a sharp drop from baseline and a quick return to baseline caused by umbilical cord compression. So we can see this cord compression, a lot of times the cord just gets in the way of something. It gets trapped between the uterine wall and baby's shoulder or something, okay? Occasionally, cord compression, we can see this variable if the cord starts to prolapse. That means it comes out of the cervix before the baby comes out, okay? That would be an emergency if we had an umbilical cord prolapse. So when we see these variable decelerations, we want to assess mom to make sure we don't have umbilical cord coming out, okay? Other interventions for this, we do need to intervene for variable decelerations. We can change mom's position to try to move baby off the cord, and we don't know, we can't see in there, so we can't see where that cord is trapped, so we just have to try different things, right? We can roll patient to one side and see if they start to resolve. If not, we can flip to the other side and see if they start to resolve. Just move patient around to see if those decelerations start to resolve, okay? Typically, babies will have good oxygen reserve in between. This baby looks like it has moderate variability in between those decelerations, but we can always administer some oxygen to these patients, maybe to get a little bit more oxygen circulating. I don't always do that right away with variable decelerations, but I can if they continue. If they persist, we'll give mom a little bit of extra oxygen. Maybe an IV fluid bolus to just increase perfusion, okay, to the placenta. Even though that's not a placental perfusion issue, it can just increase the oxygen that's going through the placenta so baby gets more in between these drops in baseline, okay? Big thing with these would be to change maternal position, okay? If they persist like this too, we would want to turn oxytocin off. If we're inducing this patient, she has an oxytocin drip going, and she continues to have these drops in the heart rate, we'll want to go ahead and discontinue that induction for now until baby is happier with everything that's going on, until we've gotten that cord out of the way. And then late decelerations, you see those in the last slide. They kind of look similar to early decelerations, right? They gradually drop and they gradually return to baseline, but we call them late because they're not back up to baseline by the end of the contraction, okay? And you can see on that slide, sometimes they even start after the start of the contraction, and then they come back up after the contraction has gone back down, okay? So those are late. They come late in the contraction. They return after the end of the contraction. Late decelerations are caused by uteroplacental insufficiency, so that placenta isn't perfusing oxygen very well for some reason, okay? We need to promptly address late decelerations, okay? They're kind of a non-reassuring sign, especially if they're repetitive. Now, occasionally, I'll see occasional lates when I'm caring for my patients. I'm not going to act on the first late. I'm not going to act on the first anything that I see, okay? If I see an occasional variable, I'm okay with that. If I see an occasional late deceleration and it doesn't persist, everything else looks fine, I'm okay with that. We're not worried about an isolated event. This is persistent lates. This strip, looking at it, I don't like the way that looks at all. So tell me about the variability there.
Dropping close to low baseline.
Yeah, well, our variability is absent, so we don't have any variability at all. That line in between the decelerations is smooth, okay? So I don't like that. That shows me that my baby is not tolerating this at all. What else can we say about it? What about our baseline fetal heart rate? Look how high that heart rate's going. That happens because baby's trying to compensate for that lack of oxygen by, just like we do when we have lack of oxygen, our heart rate goes up, or our heart rate just starts pumping really hard to try to pump oxygen. So that's what baby's doing, trying to get oxygen. So I don't like anything about that strip. I would be concerned if that was my patient. Usually we catch them before they get to this point. For this case, we're going to position mom in a left lateral position. We're not trying to roll baby off a cord. We're trying to increase placental perfusion. So usually left lateral position will do that. We want to administer oxygen. We want to discontinue oxytocin for sure if we're administering that. We want to administer an IV fluid bolus, okay? 500 usually, sometimes even 1,000. We're going to assess for maternal hypotension because hypotension can cause that decreased placental perfusion. So we want to make sure that her blood pressure is okay. We might see this right after an epidural if mom's blood pressure drops. And we're going to talk about that when we talk about epidurals here in a minute. Got to hurry. So we might even go ahead and do a vaginal exam on this patient to see what she's dilated to, because we're going to notify the physician or midwife for sure about this patient's strip. Anytime we intervene, we want to intervene first, okay? But then we also want to let the provider know what we've done, okay? We have orders for all of those interventions, typically as standing orders to administer oxygen, give a fluid bolus. We have orders for all of that already. They give those orders, you know, if you need to do this, and then we call and let them know what the outcome is.
That would all be like all patients,
Say the standing orders? Yes. They usually put those orders in as soon as the patient's admitted. And so we have kind of a, you know, toolkit to pull from. We can do all of these things because we already have an order for it. And then we can let them know after. Because we need to intervene with some of these things pretty quickly. If we're talking about oxygenation, we need to make sure that baby's well oxygenated. This is just a mnemonic to help you remember what causes what. It'll kind of help you maybe on the test when you're kind of thinking about it. So if you write veal chop like this down your paper, then look across. Variable decelerations happen because of cord compression. Early decelerations happen because of head compression. And then we had to put something else in there to make it a word, right? So accelerations are okay. We're not really talking about accelerations here, but accelerations are good. We want to see those. And late decelerations are caused by decreased placental perfusion, okay? So it's just a little way to remember what's causing what. Everybody get that? Okay. All right, we're going to talk about this quickly. You don't have to memorize all of the steps in this, but I do want you to know about the 3-tier fetal heart rate interpretation system. And it's just a way that we can quickly, for one, notify the provider of what's going on with our patient. If doctor calls to check in to see how her laboring patient's doing, and I can tell her, you know, we're category 1 and she's contracting every 3 to 4 minutes. So she knows her baby's good. Category 1 is considered normal in the book. Strongly predictive of a normal fetal acid-base status if we have a category 1 tracing, okay? And so in order to be category 1, fetal heart rate needs to be in normal baseline range. We have moderate variability. We don't have any variable or late decelerations. We can have early decelerations, though. Remember, that's normal. Accelerations in the heart rate can be absent or present as long as we have good variability. Remember, I said we don't necessarily have to see accelerations to be reassured that our baby's okay. We like to see them, but we don't have to have them. So we don't have to have accelerations for our patient to be in a category 1 tracing. And we don't have to intervene with this tracing. We're going to continue to monitor, continue to labor this patient, continue to induce this patient with a category 1 tracing. A category 2 tracing is indeterminate, or the book says equivocal maybe. So we don't have enough reassuring signs to call it a category 1 tracing, but we don't have enough non-reassuring signs to call it a category 3 tracing. So there can be a few things that we don't necessarily love on this strip, but overall, there's nothing that just makes us want to run to the back to, you know, get this patient to C-section right away. So baseline could be bradycardia or tachycardia, but we have good variability still. So variability, that's the key. Variability is really the key. If we have moderate variability, then we're reassured that our patient is doing well, our baby's doing well. You can have some changes in variability for a short period of time, like decreased or marked without decelerations. So our baby can be in a sleep pattern, a sleep cycle, or whatever, okay? No accelerations with scalp stimulation. Remember, that would be a reassuring sign. So we're not necessarily super worried about it right now, but we didn't get what we wanted there. Decelerations, variable or late with moderate variability. So I still have variability here, even though I'm having some decels that don't look really reassuring. Prolonged decelerations, that's one that we didn't talk about when I said there were 4 types of decelerations we might see. Prolonged is the 4th. And a prolonged deceleration is a deceleration that lasts longer than 2 minutes but less than 10 minutes. So you have baby's heart rate down for a prolonged period of time, and that's why it's called a prolonged deceleration. Prolonged decelerations don't mean that we need to run to the back for a C-section necessarily. Typically, baby will actually do better in utero, if heart rate can go back up, than if we ran and took baby out by C-section with a deceleration. But a category 2 requires evaluation, continued surveillance, and reevaluation. We would want to use our interventions that we talked about repositioning, turning off Pitocin, IV fluid bolus, all of those interventions that we talked about. We would want to do these. Oxygen, we would want to do these if we have a category 2 tracing to see if we can get back to a category 1 strip, okay? And then category 3 is abnormal. We have absent variability, recurrent late decelerations or recurrent variable decelerations, or bradycardia with with absent variability. A sinusoidal fetal heart rate pattern, I'm not going to talk about that pattern. It's in there, but we can talk about that in clinical if you want to know about that. It's pretty rare, fetal heart rate pattern, but it's a non-reassuring pattern. Sustained category 3 tracings require prompt evaluation and really prompt action, okay? So just because we have a category 3 tracing doesn't mean, again, that we have to run back to the back for a C-section, but I'm a lot more nervous about a category 3 tracing. So definitely want to act promptly with the category 3 tracing, want to use my nursing interventions and orders that I have on hand. And if those don't work, we want to quickly let the physician know these aren't working, and usually we're going to prepare this patient for a C-section or the fastest delivery route possible, okay, which C-section typically, unless baby's crowning, okay. Possibly. If baby's crowning and that's the fastest method, then the physician can do that if the physician's there already. If this was a quick, she became complete quickly, then I would usually call the physician that was on hand. We have a hospitalist at Baptist, so a doctor in-house all the time, so I would call them to come in and get the baby delivered if I saw this and it wasn't getting better. Okay, that was kind of fast and furious, 3-tier fetal heart rate. Any questions about that before I move on?
So would these be in more like active labor stages rather than like really early on? Because would you expect to see as much variability in like the first stage of labor?
Yes, I would expect to see moderate variability in all the stages of labor in a term baby. Preterm babies won't necessarily they should have decent variability. They won't necessarily have big accelerations. But I would expect to see these in even if a patient's not laboring, even if she comes in for a non-stress test just to be evaluated and I'm monitoring her baby, I would expect a category 1 tracing. Yeah. So this just doesn't pertain to labor. It's anytime you're monitoring a pregnant patient. Any other questions? Quickly, we'll talk about the pitfalls associated with technology. It can dehumanize the nurse-patient relationship. We tend to maybe focus on the device a little bit more than our patient. We have our patient there in bed and we look straight at their monitor to see what their monitor's doing instead of looking at our patient. We can also ignore some of our own intuition or our own observation just based on, well, the fetal monitor looks okay, so everything must be okay, but that's not always the case. So that's a pitfall associated with technology, is we don't necessarily use our gut and our nursing intuition as well when we have this monitor saying everything's great. And technological language, when we're talking about all of these things, it's kind of hard, even for some of you, I bet, to all these words that we're using: decelerations, accelerations, variability, variables, TOCO. All these words can make it confusing for patients and make patients a little bit nervous when we're using all this language. So try not to use real technical language with patients unless they're familiar with it or unless you've explained it to them. And this just talks about nursing implications for that. Just make sure you're educating your patient a lot. We're not just looking at the monitor, and make sure you really focus on your patient. Fully explain the monitoring process to your patient, what we're doing, what the different monitor parts do, and interact with your patient before you look at the monitor. Don't walk straight into the room and look at your fetal monitor. Look at your patient. Okay? And that's just a little review slide. I'm just going to skip past that. You guys can look at that. And I do have a fetal monitoring quiz too, but I don't know if we have time to get to it. I might skip over that too. But I can post that. I can post the quiz so you can look at it. Okay? Okay, let's talk about pain management for childbirth. Find my slides here. Those are your objectives. They're posted, or they're in the objectives, the same objectives that are posted on D2L. Okay. So labor pain is unique in that. Here, let's play the slide. That'll probably help. Not from the beginning. Oh no. I'm challenged when it comes to this, guys. Technology's not my thing. There we go. It's normal. Labor pain is normal. It's a normal type of pain. It's uncomfortable, but it's still a normal part of the normal process. It's not part of a disease process. It doesn't mean something's wrong. It's pain associated with a normal function of the body. It can even be beneficial because some discomfort can cause mom to change positions into a position that actually allows baby to rotate into a better position for delivery. Okay? So it really has a function. It's a normal functional type of pain. There's preparation for it. So anyone who's pregnant knows that baby's going to have to be delivered at some point. More than likely, labor is going to occur. And so women have time to prepare for this type of pain and to have some education, kind of know what they want to do for pain. So you have preparation. It has an end. You know that at the end of all of this isn't pain that's going to go on, like with the disease process, you don't know how long it's going to go on necessarily. Is it going to be weeks, months, years even? With labor, you know that it's going to begin and then it's going to end. The baby's going to be delivered and the pain is going to be over, okay? It's intermittent. So contractions occur, they're uncomfortable, but usually in between contractions, patients are pretty comfortable, okay? So it's not just a continuous pain, it's intermittent pain. And then there's the emotional part of labor pain. Concern for the baby will often encourage moms not to use some interventions for pain because they're worried about the baby. And it encourages mom to tolerate more pain than she normally, might normally be able to tolerate if she was just concerned with herself. If you break your arm or something, it's just you that you're thinking about. But with labor, moms are thinking about their babies too. I think the next class is filing in, being noisy out there. Maternal pain during labor. The sources of pain are the tissue ischemia is hypoxia of the uterine muscle during contraction. So the uterine muscle contracts and you don't have blood flow to that tissue. So that hypoxia of the uterine muscle. Cervical dilation is a source of pain. Pressing and pulling on the ligaments that support the uterus that can press on pelvic bones, press on fallopian tubes, ovaries, any other structures residing next to the uterus pressure on those structures can cause pain. And then distension of the vagina and perineum, just as that starts to stretch as baby's moving through, that's a source of pain. Factors that affect the woman's pain response: intensity of labor. So short labors can be very intense sometimes, and there's no time for pain relief if there's a rapid labor. I think somebody needs in. Long labors can decrease women's tolerance to pain, though. So there might be time for pain relief, but if she wants a natural labor, maybe no pain relief, no pain interventions, her tolerance for that might become affected by that long labor process, okay? Fetal position and size, we're going to talk about that in another lecture, but that can affect the pain response and how painful labor is. Characteristics of the pelvis, and we'll talk about that also in another lecture, but the shape and size of a woman's pelvis can affect the pain that's experienced during labor. Fatigue, a patient or mom who's really tired, who's been laboring for a long time, or who was up all night the night before and then went into labor early in the morning and hasn't had any sleep, that can affect pain tolerance and the pain response. Interventions of caregivers can affect that. So when I'm in there messing with my patient, adjusting fetal monitor belts or whatever, starting an IV, putting a Foley catheter in, all of those can increase the pain response because sometimes it's just too much. Just messing with a laboring patient is just too much. All of those interventions can make it seem more intolerable, that pain response. And then psychosocial factors: culture, anxiety or fear during labor, previous experiences with pain. If she's had a bad experience with pain, or maybe she had a really horrible labor experience the first time, she's probably not going to tolerate as much this time because she's nervous about what it's going to be like this time. Childbirth education can affect that. Is this patient prepared for what they're going to experience or not? If they're not prepared, that can affect the pain response as well. And then their support system. Patients who have a good support system typically can tolerate labor a little bit better than someone who doesn't have a support system and is just by themselves and anxious about all of this. Isn't that cute? I thought that was so cute. I like baby pictures. I like to put baby pictures in here. Adverse effects of excessive pain. Psychologic effect or physiologic effects. Increased metabolic. The pain can cause increased metabolic rate and demand for oxygen in the mother. Okay. Reduced blood flow to the uterus and placenta. It inhibits the uterine response to oxytocin. So excessive pain, the uterus may not respond to that oxytocin either secreted by mom or that we're trying to infuse, and can inhibit labor progress. So labor progress can actually be slowed down by a mom who's experiencing a significant amount of pain. Psychologic, mom, if she's had a really hard, painful labor, might have difficulty interacting with the infant after labor due to exhaustion. So we kind of talked about that in bubble he, maybe not bonding with baby. We would need to consider that, right? If we were looking at that, this mom's just had a 2-day labor that was just horrific, then that might affect her bonding right away with baby, right? Unpleasant memories can affect her response to sexual activity or even another labor, okay, if it's a really horrible labor. And it can also, the psychological effect can be on the woman's partner too. The partner might feel inadequate as a support person during labor. If the partner isn't able to help with this process and mom's really uncomfortable, that can affect her partner. Try and talk about all this really fast. I may have to post my notes though if I don't get through it all, okay? Non-pharmacologic pain management. There's all kinds of different things. Ambulation, supportive positioning, hot or cold, depending on what the patient wants. Does the patient want heat on their abdomen or do they want cold on their abdomen? That just depends on what the patient wants. Touch and massage, hygiene and general comfort. We talked about that in bubble heat. If mom's got wet stuff underneath her and everything, then her tolerance for pain isn't going to be as great. So we want to help keep her clean, keep her comfortable. Having a support person present, breathing and relaxation techniques or some non-pharmacologic pain management. Hydrotherapy, so warm bath or warm shower can help. These non-pharmacologic pain management techniques, we want to use these with every labor. So even if I have a patient who's planning on having an epidural, I still want to know how to help her with these kinds of things, because what if we have to wait for the anesthesiologist to come to administer her epidural? Or what if she wants to wait a little while? She wants to wait until she's a 5 or, whatever. She has a magic number. I want to be able to help her get through that up to that point that she can get her epidural. So it's important to be able to help with these other methods other than just pharmacologic. And some patients come to the hospital too late to get an epidural. So we want to make sure that we can help with that. Okay, pharmacologic interventions. I've got 5 minutes. Can I do it? Systemic analgesics, inhalants, don't worry about those. Nitrous oxide is something that is being used some places. That's not routinely used anywhere around here. We're not going to study. You don't have to study that. Don't worry about that part. Opioid analgesics. Typical ones that we use for labors are fentanyl, Stadol. I was going to try to not give the brand names, but I have such a hard time saying the generic names. So butorphanol is Stadol, and nalbuphine is Nubain. And those are kind of the typical narcotic meds that we'll use, or opioid analgesics that we'll use in labor. Side effects, though, what do you think side effects of those are? Constipation, we're not so worried about that. What would be a concerning side effect? Respiratory depression, right? And that's actually more of a concern with the newborn. It's more likely to occur with the newborn. So we give these systemic analgesics, and this baby's going to get that drug too. And baby's delivered and then has respiratory depression. So we're a little bit more concerned about those with the newborn. We definitely don't want to give those close to delivery. Okay? If our mom is getting close to delivery, if she's 8 or 9 centimeters, these are not what I want to use for her. Okay? That adjunctive drugs would be things like Zofran and Phenergan, Benadryl, just drugs that can kind of help mom relax but don't necessarily affect the pain. Okay? Side effects of those would just be a lot of drowsiness. You might have a really drowsy mom that has a hard time pushing, but babies typically don't have a lot of side effects from those drugs. We're not going to talk about sedatives either. General anesthesia, we use those in emergency situations when mom doesn't already have an epidural and we've got to get baby out fast. We don't have time for a spinal. Adverse effects, maternal aspiration of gastric contents, respiratory depression, uterine relaxation is a big one for that. It can cause the uterus to relax enough that when mom wakes up that it still wants to relax. And what is that? A soft uterus is boggy, and a boggy uterus is usually doing what? Bleeding. Okay, so postpartum hemorrhage is a big risk with this patient. Regional anesthesia. We're not going to talk about paracervical block. I'm probably going to go ahead and skip over pudendal block, but go ahead and read about that in your book, okay? Let's talk about spinal and epidural real quick, and the rest I will post my PowerPoint, and it's got my notes, okay? You've got a PowerPoint posted, but it's the student version. I'll post mine with my notes so you can look at it. Spinal, where am I? Spinal, they use those for C-sections typically, or just quick anesthesia. A spinal is administered in a different space. I'll show you that image right there. And usually they'll put a needle in, administer medicine in that, and then they'll pull the needle out, everything. There's nothing left in the back, and there's nothing left to pull out afterwards. With a spinal, we want to watch for maternal hypotension, bladder distension, because patient can't feel that she needs to empty her bladder, and a spinal headache can be a risk for that. Okay? Nursing considerations, we want to administer a large IV fluid bolus before the spinal, place a Foley catheter to prevent bladder distension, And if patient starts to have a spinal headache or a real severe headache and we think it might be from that, we want to encourage bed rest, administer IV fluids until that either goes away on its own or there's some other interventions that we can use for that. We can talk about that later. Epidural goes into a different space. They actually use a similar needle, but they thread a catheter through that. Then they'll take the needle out, and that catheter is left in place there in that epidural space and administers continuous medication. Okay? We're still concerned about maternal hypotension, bladder distension, so we're going to want to make sure she has a Foley and that we've given an IV fluid bolus, and we're monitoring for that. We'll have to remove the epidural catheter after labor is over, okay, and it just really just kind of pulls out of the back. It's taped in, and you just pull that out. There's not so much of a risk for a spinal headache with an epidural, okay? Make sure I got everything. Let me just show you this next slide. It shows proper positioning for an epidural or a spinal. You want your patient to really curl around the baby, not so much leaning, but really curling to open up that space for the physician to be able to place that epidural. And the epidural space is not really a space, it's a potential space. So it's really kind of just a collapsed membrane, and it opens up into a space when they infuse that epidural medicine into it. Okay, pain was really fast, I'm sorry. I didn't have as much time as I thought I was going to have. But I will post my PowerPoint. It does have some practice questions. It also has my notes. So just look for it underneath your other PowerPoint where you found that. Just look for it. I'll post it right under that. Okay? Also, one more thing. There's a bonus assignment that you can do for this. It's reading fetal monitor strips. There's 4 strips. And I'll give you a little worksheet to fill out to show what I want you to answer. You'll submit that to a Dropbox that I'll open up. I'll post the